Good evening, everyone. Thanks so much for joining us for this ACFAS Virtual Journal Club. Please take a moment to fill out the poll. It should have popped up right in front of you. That just lets us know how many of you are in attendance tonight. I'm Rachel Albright. I'm the immediate past chair of the ACFAS Research Committee, and today I'm joined by the Pediatric Foot and Ankle Fellowship in New Jersey under the directorship of Dr. Mark Solomon, and I'm also joined by the current fellow, Dr. Hu. We're also pleased to welcome PICA as our sponsor for tonight's Journal Club. PICA is represented by Dr. Katie Swanstrom. She is the West Coast Regional Lead of PICA's Medical Advisory Committee, and she's the scientific chair for AACPM's DPM for a Day, which is part of the Feet on the Street initiative that promotes the profession of podiatric surgery. She's the chief of staff at Valley Hospital in Spokane Valley, Washington, and is proud to be the first podiatric surgeon to serve in this role. So we're really thrilled to have Pica with us today. So thanks so much for your sponsorship.
Thank you.
And without further ado, we'll start our journal club. So I'll turn it over to Dr. Hu, and he'll go through these articles with us.
Hello, everyone. Well, thanks for being here today. My name is Haoning, current fellow under Dr. Solomon in Cedar Knolls, New Jersey, at the Pediatric Orthopedic Center. So today I'd like to talk to you about two articles with the common theme of using selective CTs in transitional ankle fractures. And for those who don't know, it's essentially a type of ankle fractures you get in adolescence as a kid's growth plates start to close and as they become a little adults. So essentially, the essence is, can we use plain radiographs to identify clinical meaningful displacement? So the this topic matters because it deals with Tillow and triplane fractures, both Salter-Harris 3 and 4 type fractures. And management of fractures often depends on the amount of articular displacement. So the question is, do we need to get CT if you see our displacement on the X-ray? CT is more precise, yes, but one can argue it adds radiation to the patient, it adds cost, it adds time, and do you really want to wait at 2 in the morning for the results of radiologies to read a CT for you to do something about it, right? So, can X-ray identify patients who truly need CT? Now, just want to clarify, the question is not addressing whether CT is more accurate, it's addressing whether plain radiographs can tell us when CT is necessary. So the first article is by Greenhill et al., published in 2024 in the Journal of Pediatric Orthopedics. It's a retrospective 10-year review at a level 1 pediatric trauma center, including 87 triplane-only fractures, Salter-Harris 4 essentially, with complete X-ray and CT imaging, included patients 16 years or younger, and only included patients with X-ray and CT of acute and radiographically verified triplane fractures. They included 3 different raters who were independently blinded, and they used the interclass correlation coefficients. The exclusion criteria for this study is CT scans greater than 1 week after injury. They did manipulation between X-ray and CT and poor image quality and failure to follow up for radiographic healing. So here I'm kind of showing you one of the figures on the paper. It kind of gives like you a visual example of kind of like the main point where the modest metaphyseal displacement on lateral, for example, here 2.1, and they measured, can correspond to a much greater gap on CT measured at 4.1 millimeters. The authors kind of use this to argue that X-ray can correlate with CT in specifically on the lateral view. So going over some figures again, this table 1 kind of showing the comparison demonstrates that displacement measured on plain radiographs is consistently less than displacement seen on CT, where the biggest mismatch occurs on the sagittal plane, so essentially on your lateral view, where the lateral radiograph measured about 1 millimeters, but the sagittal CT measured 3.3 millimeters, and with axial CT showing the greatest displacement at around 4.2 millimeters, kind of reinforcing that the idea that X-ray alone can miss significant, meaningful articular diastasis. Another figure they presented is comparing operative and non-operative patients. So I should have mentioned this beforehand. Out of 87, 65 were treated operatively. So about 75% of patients were treated operatively. So going back to this, this table kind of shows that if you pay attention to the bolded words or bolded numbers, that the mo CT was the modality kind of where most clearly distinguished between the two groups. And X-rays were often similar between groups, whereas CT gap measurements were significantly greater in those that were operative. So, like I said before, they used three different raters that were blinded to each other. The inter-rater reliability, as they calculated, was pretty good at 0.84. And they kind of gave kind of like the conclusion that if metaphyseal displacement was greater than 1 millimeter, there can be a correlated greater than 2.5 millimeter gap on the CT with a positive predictive value of 94% and a negative predictive value of 39%. So essentially, it's kind of saying that the X-ray is not a good rule out test because of the negative predictive value is low. It works better more as a rule in if you see the gap for a prompt CT. So some of the strength of this article essentially deals with its simple radiographic parameter. You got three people, give me your measurements, and then let's see the correlation. But one of the strength and at the same time weakness is that it deals with a triplane only cohort. So it's very specific to that patient population. But because it only deals with triplane, the first instinct of anyone hearing a triplane fracture is to, okay, let's go in and fix it, you know. Some of the limitations when it comes to this is it's a retrospective study, so it's always selection bias, and they specifically selected people from their population with both X-ray and CT, which when you're dealing with triplane fracture, and especially with the numbers of the study more biased towards the operative cohort, that can create some limitations when it comes to data presentation. It's at a single center, and most of this result will need some type of prospective validation, some of their essentially their conclusions. So, in summary, greater than 1 millimeter of lateral metaphyseal displacement on the lateral X-ray strip prompt CT as it correlates with a 2.5 millimeter, greater than 2.5 millimeter on the axial. So just going over some of the questions in the worksheet there. So number one is this represents spectrum of patients. I mean, in a sense, yes, but it only represents the triplane cohort and in a pediatric trauma center, but somewhat biased more towards severe injuries because, like I said, it's more so to do with more traumatic type of injuries as it does with a triplane. Second question, was the reference standard applied regardless of the index test results? I would say yes. Among the analyzed patients, CT was applied regardless of radiographic findings, and because X-rays and CTs were both required for inclusion. And next question, is there a blind comparison between the index test and the gold standard? Well, in this case, the CT is the gold standard, which, as you know, it's not debated really whether CT does have high sensitivity and specificity to relating to ankle fractures, both pediatric and adults. So every single one of these were compared to CT. And lastly, does it permit for replication? So I believe so. The inclusion criteria was fairly clear which type of radiographic views were used and which CT views were used, and specifically their measurements on correlation between X-ray and CT. But while this being a kind of like a retrospective study, there's always patient selection bias. In addition, maybe some type of their instruments that they use on different, applications can differ somewhat. So this might be it, but given these results, that I think it is fairly replicable within another population. So I'm going to turn it over back to Dr. Albright to see if I missed anything for the first article.
If I can unmute. Awesome. Um, can we go back a little in the appraisal sheet, maybe to the first question? Yes, love it. Okay. Um, so anyone in the audience who has been to our journal clubs know that we can't go through a JC without talking about if the article is valid. So we go through these critical appraisal sheets. These are free online from University of Oxford, and it really helps you dive into the internal validity of a paper, which is the whole purpose of a journal club, right? And when we're reading this paper on the surface, it sounds pretty reasonable. I thought it sounded pretty reasonable on the surface, maybe. But then when we go through this appraisal sheet, we start to identify where the issues are. So, for this question, is it a representative spectrum of patients? I mean, I would argue it's probably not, because of exactly what Doctor Who said. 75% of these patients were surgical. Are the non-surgical patients maybe the ones that I don't want to say the more important ones, but in the outpatient setting, are we trying to determine if people are surgical or non-surgical and whether we need the CT or not? So if most of these patients are surgical, how generalizable is that to our practices when we're really trying to make these hard decisions? You also want to see a range of disease states. So you do want people that have a mild, like so mild that you don't even totally know if they have a triplane fracture. Like those people should be included and be getting CTs to see how valuable is this really? How predictive is this really? So the fact that they only chose cases where people got a CT at the very first encounter, I think is a huge bias, which Doctor Who did mention. So I agree with you on that. But I would say probably no. I don't think this is that helpful for us generalizable in practice. That's just my opinion. But we can move on to the next question. We'll go to that one. I agree with you. I think the reference standard was applied to everybody because of, again, a bias, because you couldn't be included in this study if you didn't have it. So a bit of a convenient sample, but technically it was applied to everybody. And the next one, this one, I think this is interesting to just talk about a little bit more. This is so first of all, they're comparing an X-ray to a CT. Is a CT the gold standard for for this problem? So if we wanted to determine how much displacement is present, is there something else we can do that has a higher accuracy level than CT? I don't know. I mean, that's not totally a rhetorical question. You guys can chime in if you want. But like a lot of people say maybe arthroscopically looking at the joint, like physically looking at it, might be a more serious gold standard than a CT. I don't know. Do you think so or
You know what I think is actually kind of interesting about this whole study is that, and correct me if I'm wrong, but I don't really remember them talking about any of the typical distortions that you get with X-rays, such as parallax, or
sure.
really that distortion that you get with whether the X-ray tube has a convex base, kind of like a fluoroscope, whether there's a magnetic field present, because that can kind of change uh, everything with the X-ray as well. So it, having it greater than the 2.5 millimeters, I don't think that they accounted for distance from plate to tube and the actual projection effect either. But so that's that. I mean, the one thing I wanted to kind of chime in before is like, I don't know that there's a lot of like little triplane fractures that you're not gonna operate on. I think that uh, 75% probably do go to surgery.
Mhm.
Not that there's any like uh, data that will back that up either. But the better question for you, Dr. Albright, is what other comparison groups would you use for this? If like you didn't just use triplane fractures, just like kids, but other types of Salter-Harris fractures, or like, and what would actually make it a better study in your opinion?
Well, speaking only from the perspective of validity and methodology, and not from the perspective of like a surgeon, is you do want to do this prospectively, first of all. So retrospectively is the exact issues you're saying. You can't control for the different variables around how that film was taken, views, angles, whatever, as easily if it's retrospectively. So you want to do it prospectively. And the purpose of this study was to determine if this test is useful and accurate. And in order to do that, you do have to have a spectrum of patients. So I think it's okay. I probably would have included all pediatric fractures um, in order to make sure that you didn't lose anybody. So that how many people, you know, were not included in the study because of the inclusion criteria being the way it was and it being a convenient sample. So I think methodology wise, you want to do it that way. And there's, another thing is that they didn't look at sensitivity specificity, and that's a big no-no. So if you're looking at the accuracy of a diagnostic test, you really have to look at that. ICC is not telling you the accuracy of the test at all. It's just telling you how repeatable it is for people to keep measuring these angles over and over and over. So I would say that they didn't even really look at the right tests. So
There's lots of problems with this study. I
there's lots of
wholeheartedly agree.
problems.
Yeah.
But I do like the idea of trying to simplify the work we're doing in the outpatient setting, maybe, but yeah. Other thoughts from anybody? I think we're good on this question. But the other part of that diagnostic appraisal is the results section, which if anyone in the audience has it, you can see that they didn't look at the correct results, just FYI. All right, back to you.
Okay.
Joy.
All right, great. Let me bring you back to the second article that I have. This is an article St. All published in 2025 in the Journal of, I believe, it's Children or Orthopedics. But unlike the first article, it takes include both Tillow and triplane fractures. And again, Salter-Harris 3, Salter-Harris 4 at a rate of 55.7 and triplane and 44.3 Tillow fractures, including 61 transitional ankle fractures. Again, with three independent evaluators measuring angles on Mortise, AP lateral, CT. They included patients 18 years or younger with, again, both radiographic x-rays and CT imaging at the time of presentation. And they excluded patients with multiple level, basically super high energy fractures where there's other fractures elsewhere in the body. And just a quick thing to mention is that they kind of found that several X-ray parameters correlated with CT displacement, with the strongest being the lateral epiphyseal displacement. So again, they measured this, three independent reviewers that were blinded to each other. They looked at the different type of views mentioned here, and CT, again, looking at CT that measure displacement, diastasis, and gap characteristics. And most observers showed good to excellent inter-observer agreement. So kind of like the results stating that Mortise, tip fib clear space, Mortise articular displacement and lateral articular displacement kind of correlated with CT, with the strongest correlation on the lateral epiphyseal displacement. In comparison to all of that, the AP-based measurements were actually the least reliable when it comes to classifying, seeing how much displacement there is. So kind of going over the data that kind of supports this. At first, they look at inter-rater reliability and the correlation of that, which shows that most of the radiographic and CT measurements were reproducible, at least between observers. But the AP view, if you could see there, it ranges from negative, actually negative to was the least reliable, with the Mortise and lateral measurements performing better, and CT diastasis had excellent reliability on. The next chart I'd like to go over is the table 4, what kind of shows radiographic measurements correlate with CT displacement with the strongest relationship between lateral epiphyseal displacement and CT diastasis, while the Mortise tibiofibular clear space, again, just kind of like saying the same thing, articular displacement and lateral articular displacement showing significant but weaker correlations, where most other radiographic measures, especially on the AP view, were not significantly associated with CT displacement. And these numbers are saying as a Spearman rho, which is essentially just correlation factors ranging from like -1 to 1. So that's how you kind of evaluate, with the bolded numbers being statistically significant in terms of this. So the strength is, it compared to the first one, it does include a broader spectrum of patients with different type of fractures, again with multiple evaluators, good and resulting good reliability. But again, it's still the same type of retrospective study that we mentioned before, where there's no specific criteria on how the X-ray were taken, or like Dr. Solomon said, that many different varieties can vary in the read of how much gap there is. It's still single-centered, and it does have fewer minimally displaced fractures for comparison. But in conclusion of their it's basically saying that increased articular displacement on the Mortise and lateral view, as well as increased tibiofibular clear space on the Mortise view, kind of correlates with increased displacement on CT. So just going over this, I mean, was it representative of a spectrum of patients? It's only representative of those patients who have a Salter-Harris 3, Salter-Harris 4 fractures that with operative management. However, again, being a single retrospective cohort, it's always biased towards patients who are selected for CT evaluation. Next one, reference standard was applied as amongst the patients. CT was applied regardless of radiographic findings, since all analyzed cases had X-ray and CT. And then again, I mean, it's basically kind of saying the same thing as the first article, where it's compared against CT as a appropriate reference standard. They were compared against 3 different independent evaluators that were blinded to each other's results, so making it fairly independent. And again, replicable in the sense that it's replicable at their center, right? But maybe not elsewhere, where it doesn't give specific, instructions on how the X-rays were taken and how it was measured. So based off of that, so I'll hand it back to Dr. Albright.
Thanks. This was a pretty similar article as far as methods go. They did a really similar thing here, so I don't know if we need to necessarily go through like every single question again here, because I feel the same about the methods here than the previous article, in the sense of it was a bit of a convenience sample. Everybody had to have a CT and X-ray to be included. A little bit more variety. They did include Tillow, but I don't know. We could include some others, in my opinion. Um, One thing I found a little bit interesting is that in their table 4, that's where they have their Spearman's rho. So that's their correlation. So this is where they're trying to show you the correlation between the X-ray and the CT. And the best correlation they come up with is 0.55, which is that epiphyseal displacement, which that's the same angle or the same thing that they measured on the other article that they said was their best measurement as well. So both articles found that this same measurement seems to be the most reliable one. But the thing that's interesting is the row here is 0.55. That's very weak. That's a very weak correlation by their own standards. The way that they describe correlation in their own paper, the way they define it, that's a weak correlation. Yet they still make the conclusion that, oh, these significantly correlate, and these parameters may be good indicators for selective use of CT, even though it's a weak correlation. I think that's very overstated conclusion. The other thing I think is interesting is that they talk about the ICC, which is the agreement between the raters that are looking at these measurements. So like I mentioned, it's the same um, measurement that they find to be important, but one study, so right here in table two, thank you, the lateral view, 0.69 is the ICC here. In the other study, the ICC was 0.84. Same exact measurement. So what's the problem? Like 0.84 is excellent. 0.69, I would say, is just like good. Like it's okay. So what's the problem between how Article A is measuring it and Article B is measuring it? Is there a difference between who's measuring it? Like, I don't know, were these orthopedic attendings? Were they radiologists? It doesn't really say, but I wonder if that maybe plays a role. But I found that to be kind of interesting, that they both point at the same measurement, but they don't both get the same ICC, which tells me it's probably actually not that reliable. So I don't know. I thought that was interesting. Anyone else? Do you use this measurement, Dr. Solomon? Do you find that to be helpful sometimes, or?
Um, Sometimes it is helpful. Yeah. I wish, clinical practice, especially with kids, was maybe a little bit more exacting, like journal clubs are, but
Mhm.
it's not.
Nice.
Our real gold standard is what would we do with our own kids, especially after doing this for, 23 to 26 years in practice. That really is where the gold standard is.
Yeah,
But what I do with my own kid after seeing all the things I've done over the last 20 plus years.
sure. Yeah, I mean, care to share a pearl with the audience of like something that changed for you maybe after?
Um, so many things, but I would think one thing that constantly rings out is whenever we have patients that come in and we're concerned about transient synovitis or you know, like a little kid that has like pain that's kind of like jumping all over the place to different joints
Mhm.
and potentially had some sort of flu-like incident over the past like 2, 3 months. When I first went into practice, I kind of did more of what you see in the textbook, which is like start ordering every blood test and peds rheumatologist referrals and send them all over the place. Potentially even imaging with the need for sedation. And then after you have kids and you realize that you're torturing the poor kid and it probably will just pass if you give them a course of nonsteroidal anti-inflammatories and just watch and wait. That was one thing that changed. I kind of realized, and I say this all the time, that the way that I kind of look at what we do now is kids are kind of like bonsai trees. You're not going to be like doing big hedge clippings. You're going to be doing micro movements and just watching where this thing's going to kind of end up before you make any type of big intervention. So,
Yeah. Yeah. I think, I've heard people say that when they themselves have become patients, it's changed the way they've practiced. I know that's not exactly necessarily what you're talking about, but I think it's similar. It's like when you have your own personal experience with it, you start to realize how sometimes you can cause a little bit of harm with with all the things that we do. So we want to make sure that what we're doing is accurate and um, the benefit outweighs the risks and all these things. And yeah, I feel you.
yeah, go back to the gold standard. What would I do with my own kid?
Yeah, yeah.
Okay, then I guess questions from the audience if there's any, or and then right, and then give our
hmm
talk.
Or Dr. Swansford, did you have any input you wanted to give it?
Yeah, I had some things to add from a risk management standpoint. These pediatric fractures of long bones have unique risks for long-term malalignment or growth abnormalities. So I think it's really important, critical to document the decision for surgery versus non-operative treatment. So that needs to be very clear in the note as to why you chose surgery versus no surgery. And if you need a CT in order to do that, or in order to feel like you're explaining yourself better, I think that's appropriate. One of the main risks for surgery in this population, or for litigation in this population, is failure to treat. So if someone thinks that it should have been treated surgically down the road, and they can point to certain reasons why, and you didn't document it well, then you're kind of leaving yourself open to that litigation. Regardless of which way you go with treatment, it's important to follow the patient until skeletal maturity, so that you're seeing them back, kind of that bonsai approach. I like that terminology, to wait and see how they develop as they get to skeletal maturity. I know when I did my pediatric ortho rotation in residency, the attending said that it was like veterinary medicine. And at first I was like, okay, I'm a little offended, but then I'm like, oh, okay. You kind of, they're not really going to listen to you. They're going to heal most of the time great, no matter what you do. But it's looking out for those complications that can get you. And also knowing the statute of limitations in the state that you're practicing. It's longer than treating adults. So, for example, in Washington State, it's 3 years for pediatric patients after the index injury or surgery. But you have to keep those charts in your office until the patient is 18. So just make sure you're managing those things appropriately. And then the last issue where you're open for some risk is the informed consent. It's a lot more difficult to consent a child, in my opinion, because you're dealing with the parent. Depending on the age of the child, sometimes they understand, sometimes they don't. When they're getting close to, 15, they can understand and want to sign for themselves, but the parents still legally are the guardian and need to be involved with that decision. And discussing the risk of treatment versus no treatment is really the informed consent there. When it's a Tolo fracture, it's not an elective case at this point, it's trauma, but you still have to document very clearly. So those were my additions, but good job, Dr. Hu, on the presentations of the cases.
An interesting point that regarding consent is in the case of divorced parents, you have to make a reasonable attempt to contact both parties,
Yeah,
if not
that makes
getting
it even
consent
more
from both,
difficult.
because there has been cases. Luckily, I haven't been involved in it, but there have been cases that one parent does consent and one parent claims that they have never given consent, and it ends up in litigation.
That would be very challenging.
That would be very challenging. It is correct. So you have to make a reasonable attempt to reach out and document every way that you possibly have tried to reach out to that other parent to make sure that they consent as well. And typically, we are follow. You also mentioned earlier about following them long term. So we typically will follow them for a minimum of 18 months or skeletal maturity.
Have you ever heard of that litigation happening when the couple is married? Like still married? Where
Uh,
there's just one parent present and then the other parent's like, oh my God, you consented to that? I wish you didn't.
I'm sure it's happened. I'm sure it's happened. I haven't heard of it, but I'm sure it's happened. And even with the failure to treat, honestly, you can get sued for anything. But with failure to treat, if you're documenting it, you identified it's reasonable. You have, you're ordering a CT, you're getting the expert opinion of the radiologist as well. Uh, and you tell the parent that, if I guess depending on how much displacement, I mean, if you completely miss something, yeah, I think that there is liability. But I think if it's minor and you give the opportunity to parent after talking about risks, benefits, alternative treatments, and they decide to hold off and wait. Because I had one patient that had this that I told the parent they need surgery, and they said that the kid was going through chemotherapy, uh, and so part of this potentially was pathologic as well. And I explained the importance of taking a biopsy in this region as well and doing it, and they declined. So sometimes you tell them, you give them all the risks, benefits, everything, and they still decline. So
Yeah, and they're allowed to do that, but the documentation has to be very good on those cases. Some people will even do, have the patient sign a refusal of
AMA,
treatment.
yeah.
Mm-hmm. There is a question from the audience saying, have there been scenarios where a two-physician consent is necessary for those patients? I'm assuming that means maybe like overriding the guardian.
I've only had experience with two physician consents for patients who are in a coma and you can't get a hold of any family member or next of kin. I haven't experienced that with pediatric patients.
I would probably just call risk management and let them document it and
Yeah.
get, legal counsel for the hospital involved or whatever. There's only so much you can do as a physician, and trying to convince everybody to do everything. You can give them everything that's needed for an informed consent, but in certain situations it just becomes too difficult. You have to call in reinforcements.
I agree with the risk management situation. I've had to do that before. Um, I don't really see other questions from the audience right now. However, we'll still take questions, so think about it, guys, and don't be shy. But I do want to give our fellowship some time to talk to the audience a little bit about what you guys do. I think we know you do pediatrics, but there's usually a lot of students and residents that attend these journal clubs, and I'd love to give you guys a second to just talk about what you want people to know about your fellowship.
Sure. If I can share, I can show. I have like that PowerPoint that I used for the AACFAS fellowship Zoom room last
Oh,
week.
I'll
lovely.
I'll stop sharing if I can
I'm going
find
to
it.
replace you.
Yeah, let me try. Uh,
It looks like you should be able to share now, Dr. Solomon.
Okay, great. I'll just zip through this because otherwise it's going to be long. And so these are our partners. It's a pediatric orthopedic practice. It's the only one. It's only pediatric foot and ankle fellowship that's within the pediatric orthopedic practice in the U.S. And if it let me move, uh, it's not letting me there. Okay. So because it's a journal club, I'm just going to comically explain that most of the stuff that you end up seeing in our practice, because it's pretty rare and complex deformities, we jokingly call it the n equals one case. Most of the time, you're going to get those experiences in most of the adult experiences in residency. You don't really get much pediatric training. We started this. We're on our eighth fellow. We started this a while ago because I was a CPME site reviewer for residency programs, and going across the country, seeing different residency programs. I saw that most of the pediatric numbers that they were getting were kind of simpler things that they were seeing in the ER, pediatric, like ingrowns, infections, maybe a couple Salter-Harris, one or two. Nothing that I would consider complex. And I saw that we were able to offer a very unique experience. I spoke to my partners, and we wanted to also help educate that next generation of residents to have a little bit more pediatric experience. So, I mean, I just put a couple of pictures up, slides from some of the cases that we did. So, I mean, N equals 1 was a polydactyly case. Let me see if I can put the pointer. So you can see over here, this kid ended up with a deformity long term because he had an extra digit of a hallux removed along that medial aspect. And eventually, what was missed initially apparently was a delta phalanx that they didn't correct at the time of surgery, which ended up causing really abnormally formed hallux, as you can see here. But when they resected out the extra hallux that was on the lateral aspect, actually, they ended up damaging the growth plate of the base of the head of the second metatarsal. So they ended up getting a brachymet as well. So this is something that we ended up seeing and correcting. The case in the bottom here is a kid that was born with Town syndrome. And as you can see, it ended up having a coalition of the tailocalcaneal joint and malformation of basically the rest of the foot, both midfoot and hindfoot, which ended up requiring significant correction as well. This is the adult stuff that Rick does. He gets to do a bunch of cool total ankle cases with Dr. Justin Fleming and complex pilon fractures with lots of plates and screws. So you definitely leave with significant AO principles. This is another case that we ended up doing where a patient was treated in Iran when he was newborn until they escaped the country many years ago. It was a polydactyly that was not treated, and as you can see, it has this Y deformity where part of it ended up fusing into the fifth metatarsal, and the other part just went plantarly. So that was something that we recently reconstructed. Patients doing very well. There's a significant amount of pediatric trauma that you end up seeing as well. So this is a Salter-Harris 1 with a green stick fracture of the distal fibula as well, that we were able to actually just close reduce when the patient had some conscious sedation. So that was kind of like a unique experience. This patient on this corner over here has neurofibromatosis type 1 with a congenital pseudoarthrosis of the tibia, or what we call a saber shin deformity, where we provided some guided growth for a period of time, which obviously didn't work, as you can see before X-ray. And this is the after X-ray. We basically were able to create a double osteotomy and a cross union, and now the tibia is nice and straight. So there's a lot of very rare N equals 1 type deformities. This was his case log as of 3/12. Fair amount of pediatric ankle fractures and trauma. Total ankle replacements were about 8% of his caseload. And there's a lot of very unique, minimally invasive forefoot reconstruction, very small amount of infection or limb salvage. In fact, I don't really see any of the diabetic or Charcot patients in my practice. My practice now is somewhere between 70 to 80% pediatrics. So this is a really cool X-ray, which you may see once or twice in your career. If you see an 18-month-old come in with ankle instability when they're walking, and you actually take a look at the X-rays of the talus, and you see this thing that looks like some sort of like Death Star. This is something called Trevor's disease. So that was a pretty rare incidence, and very interesting as far as treatment course for something like that. We see a good amount of pediatric sports medicine. This is a os subfibulare that had avulsed off of the fibula that we were able to just reconstruct the ligaments, scope it. Patient was able to return to skiing about 8 weeks later. And the whole thing froze up again. So there's a lot of, most important thing if you're looking for a fellowship is to make sure that you have mentorship and teaching, both your ability to work with residents and teach others and learn how to do that process, both in the operating room and through cadaver labs and journal clubs and lecturing, but also being able to have a one-on-one experience with a very experienced practitioner so that you can see how they handle that whole perioperative period, because that a lot of times is missed during residency. Most of the fellows that do a fellowship will say that it has advanced it's almost like they had an additional 3 to 5 years of private practice prior to them entering private practice. So it really does instill that confidence. Our fellows leave seeing the most unique cases. So they're not really afraid once they get into private practice because they've learned that they can pretty much handle everything and walk into the operating room with a surgical plan from A to Z. So multiple ways to kind of fix different things. This is another very unique case. I can't even pronounce it, but it's like we just call it BFL syndrome, where you can see that there's elongated proximal phalanges, which this kid couldn't fit into a shoe beforehand. So through MIS correction, we were able to reduce the length of the toes and reduce the length of the hallux so that she could actually wear a shoe and play soccer. So it's a lot of very nice, happy moments with our kids. So this is our faculty. We have 8 fellows currently. We're going to be taking our 9th one is going to be Allison. So a lot of hospitals are not allowing surgeons to operate on pediatric patients or have obtained privileges at a pediatric hospital unless they've proven that they've had specialty training in pediatrics. So our fellowship is one of the few ways for you to obtain privileges at pediatric hospitals and operate on kids. That was a kind of a cool thing. Some rare training experience. You have a very high surgical exposure to very complex cases and mentorship. Thank you. So this is actually a little friend of mine. I have a release from him, so not violating any HIPAA things by showing this. This is my friend Caleb. He was only able. He had a windswept deformity of both feet. So one side was a club foot, one side was extreme flat foot with external tibial torsion. And we operated 9 hours on him, put a frame on the left side for his club foot and a frame on the right side because he's also has a lot of difficulty in communicating and following directions. So by putting those 2 frames on, we were able to, on the right side, correct that external tibial torsion and that flat foot and protect the foot post-operatively because he wasn't able to put full weight on the actual operative site, but able to use a frame which would redirect the weight bearing to his proximal tibia on the right, and then the left side it corrected a club foot with a miter frame. And 9 months later, him and I and his mom did a kid Spartan. I'm really good at the kid Spartan, so beast at it. So that was it. I just wanted to kind of share some of that brief stuff with you guys. I'm happy to answer any questions any participants may have about our fellowship.
Quiet audience, still no questions. But I have a question for you.
Sure.
What are maybe like the top 2, maybe 3 characteristics that you just feel like you gotta have in a fellow?
So they typically sit a foot away from me for an entire year. So they have to not have COVID. We learned that with Dr. Ahmed. I remember when the news flashed that the new symptoms, this is like a Monday morning, I think like 2 months into COVID, saying that loss of smell was one of the potential indicators that you may have it. And he like looked at me and our x-ray tech had called out and I said, oh, he apparently lost his sense of smell and he may have COVID. And he's like, you gotta be kidding me. He's like, I just went to this like really nice meal. He's like, I couldn't smell anything. I couldn't taste anything. I'm like, you may have COVID, my friend. So not having COVID, but you need to be able to be teachable and you need to be able to get along with us. So we do recommend that you do a site visit and you come see that whether or not you can tolerate me for a whole year and my partners. But we have a lot of fun. My partners are awesome. They're like my brothers and sisters. Our fellows have been awesome. They're like my children. It's been a great experience for all of us. The fellows have really even brought our whole practice together. And, I feel like I've done 8 fellowships now and that I've learned more from them, I think, than they've learned from me. So it's been a really like wonderful experience. I'm really happy that I kind of fought for it in the beginning. It's been great. We text each other couple times a week. If I ask any of them or to volunteer for anything, they're like they jump on it. It's just really nice. It's a really nice experience, right, Rick?
Mhm.
Yes, absolutely.
He chooses to be in the OR at this time of night. Just to clarify.
Well, I finished late. I couldn't, the 45-minute drive home. I would have been
Yeah.
in the car.
I mean, what did you do today? We operated on we took an X-Fix off of
Quick,
a patient with an achondroplastic dwarf that we corrected the tibia with
yeah,
a
then I did a Charcot recon with the X-Fix with Dr. Dong. And
right
then
on pass fellow.
yeah, and then Dr. Fleming had three Lisfrancs, two ankle fractures, and a manipulation under anesthesia. So,
That may be the weakest case out of
yes,
the whole day,
yes, yes,
But maybe welcomed after that day.
yes.
probably.
Give me an easy one at the end, yeah.
So
What if
that's not every day is like that, but there's a lot of very unique cases, and our previous fellows have told us that they leave this fellowship very comfortable with anything that can pop up in the OR because many of these cases you can have plan A, but you end up finishing with plan like M or N.
yeah, it's an important skill to have, yeah. How early do you want people to reach out to you?
So I'm currently the vice chair for the AACFAS Fellowship Committee, and so there's no like people can reach out and come and visit. We will not make a decision until after May 1st. That is what the standard is for the fellowship committee, as far as the fellowship committee is concerned. So we don't make a decision really probably until the end of May. Not for this year, but for the following year. So we're picking now for 2027, 2028.
Well, sounds like a great experience. I'm sure people in the audience would agree because we still have some people that hung on till the end here.
We're worth
But
it.
yeah, guys, reach out. So, if anybody has anything else they want to add, should we give people back 8 minutes of their day?
Where did you two train? Dr. Albright, Dr.
I trained
Fleming?
in Chicago, Advocate Illinois Masonic. Yeah.
And I trained in Seattle at Swedish.
So did you get to work with Dr. Mosca?
I don't recognize that name.
Who is it? Where was it? Do you remember the attending from the Peds Ortho?
Um, no, they were changing.
Okay.
One was about to retire, and then one was transitioning somewhere else. So I think there was some turnover.
I, we got to we did a really cool case on a kid that had bilateral fibular hemimelia, uh, and usually those patients get treated at like 18 months of age, but he didn't come to the country until I think around age 16. And so we reached out to our friends at to Dr. Paley and to Dr. Katie Miller, who was one of his new associates. And they have like this week-long, really awesome, complex, like really complex case course, like really complex. And Dr. Katie Miller was super helpful and really lovely to work with, gave us so much advice, and she had the most unique perspective ever. She did her one fellowship with Dr. Vincent Mosca in, I think it was somewhere in Seattle. I don't know if it was the same hospital that you mentioned at or not, but Dr. Mosca is like the one of the founding fathers of pediatric foot and ankle. And then she came and did Dr. Paley's fellowship as well. And they have opposing opinions when dealing with patients that have that fibular hemimelia issue. But what made her perspective ultra uh, authentic is the fact that she had two sisters, one of what both had the same thing. One ended up having the BK amputation,
Oh,
and one had the reconstruction.
Wow.
Because Dr. Mosca, and most of the time he'll say do the BK. Dr. Paley says do the reconstruction. So I asked her in the end what she would do, and she said what she would do with her own kid, and she said that's the greatest question. She said I would let them decide
Mm.
oh,
because there's pros and cons of both.
Yeah.
One kid that ended up having the BK. I mean, anytime they have to go to the bathroom in the middle of the night, they're hopping to the bathroom, and there's the stigma of having that prosthesis as well. Versus the one that had the reconstruction and went through the lengthy process of having an external fixator and having multiple surgeries. So even though we think we can make a decision sometimes, there are pros and cons, and I think it's better just what she said, which is just let them give them risks and benefits and see what they decide based on that.
Yeah. Well, geez, an N of two in one family. It's like double what we typically get, huh? It's crazy.
Anyway, does this usually go till 9?
Yeah. Mhm.
We were just so good in our analysis of every journal, and we wrapped up the fellowship experience so quickly that we're just
Yeah, no,
ultra
it's
efficient. We
okay.
should get
I
extra
mean,
points.
we get you do get extra points. Yeah, you
Yeah.
do. You do. Yeah.
This is going to be good for my record because last week when I had to moderate the fellowship Zoom room, I finished exactly on time. I kept 10 different fellowship programs on time, which is
That's amazing.
that is amazing.
That's
I had
tough
the
to do.
little wrap it up box, and anytime they were kind of going, I let my phone ring so that they knew that their time was up.
Yeah.
Hit the wrap it up box and moved on to the next, and tried not to
Nice.
offend anyone. So it was great.
Yeah, that's a feat, man. It's hard to keep people on time sometimes, but
It is.
we were very efficient today.
We were. We
Yeah.
were.
Well, I guess we'll let you guys go, but thanks so much for coming on.
Thanks for
Really
having us.
enjoyed talking to you guys and hearing about these articles. And thank you so much to Pica for sponsoring this. And we always appreciate your input on the malpractice side because gotta be careful out there. And,
yeah, like Dr. Solomon said, people can sue you for anything.
Yeah, and
But
you're not a bad person if you get sued.
right,
Honestly.
no, not at
yeah.
all.
Yeah. I actually, I'm going to disclose, I actually won the first and only malpractice trial that I've had in a 23 year career. So
Congratulations.
you can get sued for absolutely anything, anything.
I'm sorry it went to trial because that it's a long process.
It is a
Mhm.
long process because the case was actually before COVID, like just right before COVID. So it got delayed and delayed and delayed. But look, it's a process. You go through it. You try to learn something from it. I learned a lot from it. I
Well,
don't
that's
think
good.
anything is preventable 100%. I think you can document as much as you possibly can, and you should, because that probably makes some of the cases go away. But
Yeah, it
there's always a
protects you.
potential.
Um, mm.
Yeah.
Anyway, thank you guys so much for having us.
Thanks,
Yeah.
guys.
You.
Thank
Really great
you.
to see you.
Thank you, doctors, for participating. We appreciate it.
Pleasure. Have a great evening.
You guys
Yeah.
Thanks. You
too.
too.
Bye, everyone. Thanks.
Bye.
Bye.